So I'm going to talk about collaboration, and I'm going to show you examples of collaboration across subspecialties and across other members of your practice community who make a significant impact on measuring the benefit of what you do. What the collaboration allows you to do is to see the right patient, do the right procedure at the right time. And it allows you to use your colleagues, like all of the different people that are sitting in this room, as a force multiplier. In your practice, you might have 300 or 400 patients with one particular procedure being done. But if you gather 5 people together, as you see in this photograph, there are 5 people there whose hands are collaborating. You have that multiplier effect, and very quickly you get into case volumes that are in the thousands. And you can start doing your trending, and you can start doing your predictive analytics, and you can start doing your outcome measure with thousands of patients, and they don't have to be from your practice. So I'm going to ask you to do what we have already done in the surgical field. Begin to do this yourselves by just looking at 5 people who are sitting in this room, whether or not they're at the front or at the back, merging your efforts with their efforts, and produce dramatic impact in measuring the benefit of what you do. One of the things that was mentioned early on is there are headwinds that you will walk against. And the regulator headwind is a significant headwind. It blocks your authorization process, it blocks your treatment options process, and it can actually deny a perfectly reasonable treatment. But if you collaborate with colleagues and generate databases, you'll be able to stop that process and allow your patients full access to beneficial treatments. And the way you do it is really rather simple. There are 5 elements to this. The first thing is just find 5 people. Start small. The second thing is to create wins for those 5 people. And if the successful initial step is just get agreement around the 3 things, 4 things, 5 things you're going to measure, do that. And all 5 of you, and then the next 5 that join, and the next 5 that join. Next thing you know, you have a group of physicians that's 150 strong, but they're all measuring the same thing, and they're measuring a limited number of things. That's called being on a data diet. Because if you ask any of your colleagues here, what are the important things that you want to know, they'll list 10 things. It's okay, what are the top 3 or the top 5? And then you get all of your colleagues to agree to those top 3 or top 5, and 100% of your colleagues measure those 5 measurements on every patient. Now you have 500 people in your data set, and they all have 100% complete data. That's massively impactful. Own your own data is critically important. For those of you who will work in health systems, that's a little problematic because they're not going to let you do that. But for those of you who are able to navigate that problem, or those of you who are in private practice, owning your own data is the only element of these 5 that is highlighted. It's critically important. You have to own your own data. And then just be generous with it. Transparently report. And if that means that you transparently report in bulletins, or you transparently report at your society meetings, or you publish papers with your colleagues as co-authors, that's transparent reporting. So it's a very easy thing to do. So I'm going to show you an example of what surgeons have done in this arena. And the 2 other speakers who were scheduled to give this talk are actually on this slide. Ben, which one of these is the light? Well, I'll finger point. Jens Chapman, second row, first name. Rod Askewian, second row, last name. These are neurosurgeon, orthopedic surgeons who collaborated in this group. The other people who are on this author list are also suggestions for who you might collaborate. Sarah Core is one of the nation's most gifted outcomes researchers, University of Washington. There are Department of Orthopedic Surgery here at UW, Swedish here in Seattle, and then community physicians are scattered throughout that list. I'm in the bottom, in the middle. They're scattered throughout this list, and they contribute so that you have a merging of academic and community medicine within your collaborative, and you have experts, because you can't be an expert in the practice of medicine and the analysis of data and the proper construct of study, because that's an academic function. So what you want to do is collaborate with people who have like mind and like interest, and you can develop these hugely impactful publications. So this is, also look at this, this is a study of spine surgery that has never been done before. That's why it's called an original article. This research had never been seen at the Journal of the American Medical Association, so they signify it as an original article. And the payers then pay very close attention to the fact that you can predict, and you in your practices can predict the outcomes of what you do. And I'll show you the tool. And if you have a camera, or if you don't have a camera, remember these are all recorded so you can get back, but that's a very important slide. So this is a predictive tool, and you have these data elements in your chart. Patient's age, patient's sex, the insurance type. That's important to know because it's actually predictive. The insurance type, Medicaid and labor and industries have an erosive impact, 12 to 17% erosive impact on outcomes for appropriately selected patients. So that means it doesn't matter what your skill level is, those types of insurances will degrade the best outcome you can perform. I didn't highlight back on that author list that the author list there had the top 2% of surgeons in our state. But they had, and they suffered, these predictable degradations in outcomes based on patient characteristics, not surgeon skill. So you can do the same thing. You just pay attention to these metrics, and they're very limited. This is a data diet. You're looking at it. Age, sex, insurance. Do you smoke? Do you take narcotics? Is this a revision procedure, not a virgin procedure? Those are predictive. And they're patient characteristics. They're not characteristics of your skill. They're characteristics of your choice of patient. So the patient characteristics, they're hugely impactful. And then you have to put the objective measures, because the risk factors are things that you can impact. You can modify. They're modifiable risk factors. If the diabetes is there, is it well controlled? Do not touch anyone who is out of control in diabetes. If they're on narcotics, are they taken off narcotics? Because the use of narcotics will erode surgical outcomes. And then the objective measures, how painful is this? And I did not include, this is a NRS numeric rating pain scale, or you can use a visual analog scale. They're analogous. This is easier to use. There's also a function scale. If you're working in the extremity and you're going to do an ablation procedure on a patient who has obesity, diabetes, a messed up knee, but the surgeon looks at him and says, I can't operate on this patient. The patient's not likely to survive the procedure. You could use a knee rating score that the knee surgeons use. It's very important to collaborate around what metrics you use. If you use the same metrics as the surgeons use, your data merges. It does not conflict. And you do a procedure and get a dramatic impact, a huge benefit, or you take a revision failed total knee and you do an ablation procedure that gives the patient huge benefit. If you use the same measurements the surgeon uses, you prove the merit of what you do right up against the same merits that he uses to measure the benefit of his work. So you collaborate around your metrics. Use predictive analytics, use patient characteristics, use objective scoring systems. And you can see in this patient, this is one of my patients, her surgical success rate with her characteristics was 13%. Now, she might turn to you, as she did, and say, I'll take it. That's great. I said, no, that's terrible. If you modify your own characteristics, your narcotics, your smoking, see the gray column? That's what you would be. So before I will touch you, you must change your behavior, and this tool tells you that. So I print this tool out and give it to the patient. Now, she can walk down the street 2 blocks and go see another surgeon who doesn't do this and get operated on, and the surgeon will look her right in the eye and very candidly say, if you fail, it's your fault. Now, my ethic won't allow me to do that. I would not sign someone up for fail. I want patients who have 80 and 90 and 95% likelihoods of success. And this tool will predict it for you. And you can use these scorings. If you're doing a neck ablation procedure, use the NDI, Neck Disability Index. If you're using, if you're doing a lumbar procedure, whether it be intradiscal or if it be associated with the facets, use an ODI, the Oswestry Disability Index, or use a Promise 10, and then you don't have to pay Jeremy Fairbanks the subscription fee for the ODI. Jeremy's a nice guy, but you don't have to pay the subscription fee, or you could use a CAT 10 instead of the NRF. There are tools that are validated, accepted, proven tools to measure the benefit of what you do, and everyone on your metrics team just has to agree, okay, what tools are we going to use to measure peripheral nerve stimulation? Your spinal cord stimulation techniques would benefit from this tool because you can put into this tool each of the types of patterns that you're using for each of the specific diagnoses that you are treating. And with the force multiplier effect of all of the individuals in this room and previous fellows who have been here years before, you would have thousands of patients. Thousands of patients. In that predictive analytics paper I just showed you previously, that was based on 25,000 patients in the registry, of which 1,500 were selected to develop the tool. 80% of that 1,500 developed the tool. 20% of that 1,500 were then used to run through the tool to prove that the tool worked. And you can do the same thing with it, and you'd accomplish it within 2 to 3 years. And then any payer who would come to you and say, this procedure is, we won't authorize it, or it's experimental, or it's overutilized. You'd show them with data profoundly beneficial effects of the treatments that you use because you've enrolled them, along with your colleagues, in these types of studies, this registry. And this is, in fact, an example of how that happens. So we're developing the spine registries out here for surgery. We're up around 11,000 patients, and the head of the Medicare administrative contractor out west, which is Noridian, west of the Mississippi, the Medicare administrative contractor all the way out to Hawaii, is Noridian. And she came to us and said, I've had these 2 articles show up that say that kyphoplasty cement augmentation is a sham. And I have 110 articles that I have read, that I have looked at, that say it's a benefit. And so I've taken these 2 articles because they're published in the New England Journal of Medicine. They happen to be highly flawed, horribly flawed, but they're published in the New England Journal of Medicine. And they say that all those 110 articles are nonsense. Can you build a registry that will prove the answer to this question, does kyphoplasty work? And I told her, yeah, we can do that if you will help. She said, because what I do is I take a look at a publication. I look at the title of the publication. I look at the authors. Is there anybody there I recognize? And then I look at the bottom to see where was it funded? How was it funded? And if it says it was funded by a device company, I throw it away. I don't read it. I don't even read the abstract. If it has the word Medtronic or Stryker or Merit or Define written on it, I throw it away. I consider it propaganda. And so the 2 sham articles were not industry funded. So she believes in them. And what we did is we built a registry, and we'll talk about this in the second half of my talk tomorrow. And look at this, this registry is the world's largest. It's 3 times larger than the Switzerland registry, which is the 2nd largest. And it's all done by people who collaborate. So when you look at the authors, there's a community physician in a local community in Washington. The 2nd author is a professor at the University of California, San Francisco. The 3rd author is a professor at the University of Wisconsin. The 4th author is an interventional pain doc in a small community of the capital of Washington. And experts in registry development remain, and then Doug and Ed are also authors. This registry changed national Medicare authorization for kyphoplasty because it was real world. It proved the safety of what we do. It proved the benefit of what we do. And it proved that that occurred no matter what device was used. So all devices are in the registry and treated with the same and measured with the same outcome tools. So you can't make an argument about one device being better than the other because they're all in there. And all of their adverse events are measured and all their beneficial impacts are measured, and they're all measured agnostically of the device. Although we know, and if you wanted to pull out, okay, I want to see Medtronic's cement augmentation tool, what does the outcomes look like? Or I want to see Stryker's, or I want to see, you can pull it out. And this changed Medicare's approach. You all will genuinely benefit from doing this exact thing for each and every one of the treatments that you perform. And you just have to figure out, okay, who are the 5 people that I'm going to join hands with? And what society am I going to discuss this with? Because it helps to have a third party distant from the funding source. But that's details. But you can accomplish this, and the data cannot be refuted. And you cannot be denied authorization for a proven medical treatment, which is what's presently going on. So I'm going to hold up here and continue to show how these registries work and what they prove. But I'll take questions for now so we can stay on schedule. Yes, please, to the microphone.
I'm not sure if this works.
I can help.
Thank you very much for this very thought-provoking talk. Admittedly, I'm very tired after my delayed flight this morning, but
there's so much we need to do in terms of advocating for like the efficacy of our procedures, and I really like how you outlined in terms of data components of what we can do, like collectively to kind of like advocate for our procedures and us and for the patients like to receive them. I think this is maybe half question, half just ongoing discussion. Is it's really nice to have data points in terms of like insurance payers and other patient characteristics where like it convolutes maybe like data of the patients. But I think the reality sometimes especially in a pain and interventional sphere, it's easy from a surgical perspective being like, we'll offer surgery if your A1C is this, or if there's these other characteristics that navigate or that like preclude someone from being like a great surgical candidate versus from our perspective, at least sometimes I think of is we don't always get a clean patient population. We can't like be like this patient is on opiates, or narcotics. We can't offer these other things. So it's more like we can't have that same, because the risks with minimally invasive is so much lower. It ends up like muddying the patient population in a sense where like there's all these like confounding factors where it's like, I don't think we can so cleanly parse all of that out. I mean, it's easy to like parse out the ones who do, but like sometimes from a referral source, like you end up with only patients with all those characteristics, if that makes sense. So I don't know, like from a research perspective, like how, what are your thoughts in terms of navigating like that difference of a patient population?
If I understand you correctly, you're looking at the sea of heterogeneities, or to use simple language,
Yeah.
The sea of variation, which exists in all communities.
Yeah.
And that sea of variation existed in our communities before we started our very first patient enrollment back in 2009. We lived the life experience that you are presently describing. Mm-hmm. And what we brought to that confusion was predictive capability, understanding who is the most appropriate and best patient, a dramatic savings somewhere in the area of $70 million per 2 years for our state. So it was just a matter of the courage to put your hands in the ring and get started with the work at hand. So in a brief review, I talked about collaboration and choosing 5 people in this room who you can work with. I gave you a rough outline of what are the fundamentals of registry and how they're the integral components to assure success. I give you examples of literature that's published where collaboration between different subspecialties results in impactful change. And I showed you a user-friendly computer decision-making dashboard tool that you can use in your practice to assure that you're always selecting the right patient for the right procedure at the right time. Then I hinted at the frustration that was the original pain point for kyphoplasty from Noridian, the Medicare administrative contractor west of the Mississippi, who made a determination, LCD, that sought to eliminate kyphoplasty and was asked by them to build a registry, and we agreed to build a registry to answer the questions they had that they thought were the basis for the denial of appropriate care. And that resulted in a registry that's the world's largest registry. There's 735 people in this registry, and it proves safety. So an adverse events rate of 5 out of 1,000 is a very safe procedure. And a procedure that has a 25% cement leakage rate, which was one of the Noridian concerns, along with retropulse bone, that this was a danger and a threat to the patient population. And a regulator armed with a minimum amount of information becomes a very empowered adversary, but you can turn that adversary into an ally if you provide that adversary a valuable set of information that they can use for justifying before Congress the work they have to do. So that's what we did. And what we showed is that it's a safe procedure, that it's a highly beneficial procedure. You all know the MSID for pain on a numeric rating score is 2, and we had a 6.5 delta for our pain score, so we dramatically relieve pain. The MSID for the Roland Morris Disability Questionnaire is 5, and so we had a 2-fold improvement in the MSID. So this is a very beneficial pain relieving, and we also showed in the NNT study that it saves lives. That's impactful. This is what the data looks like coming out of the registry. As you can see, the pain relief is immediate. It's almost a sigmoidal curve at the beginning, and it's sustained. At 6 months later, you're down at a pain score of 1. And these are interquartile range numbers, the statistical dispersion numbers. And the Rowland-Morris also shows dramatic improvement in function. We showed the cost, and I'm going to jump right to the impactful slide. We showed the cost savings for Medicare was a 3-fold cost savings if they did what we asked them to do. Following on that, we built a sacroplasty registry, and since the sacrum is merely 5 lumbar vertebrae that have merged, the behavior of the bone is characteristically identical to the behavior of the vertebral bones of the lumbar and thoracic spine. The morphology is different, the biomechanics are different, but the behavior is the same. So when you look at the pain reduction, it's dramatic. When you look at the functional improvement, it's dramatic. Which means if you leave sacral insufficiency fractures untreated, the disability and the pain are horrific. So you want to treat. When you look at what the registries can do for you, and I penciled down yesterday items that would be very reasonable registry items for you. Looking in the anterior column, sources for pain, vertebrogenic, discogenic, very good territory. Large heterogeneity of diagnosis, large heterogeneity of treatment. So the different device companies, they'd all get logged in, they would all have their devices listed. Posterior spine pain, the spinal cord stimulators, radiofrequency ablation would all be ideal registry topics that you could get massive numbers on in an 18-month period of time. Peripheral nerve stimulation and RFA in the extremities. Again, another place where there are validated metrics, scores. Besides pain, you can have function scores in the extremity that are not the ODI, NDI, but they're all accepted by societies. They're all accepted by Medicare as valid scores. And you could use those to show the merit of what you do. And if 5 or 10 people from each of these fellow courses were to unite, you would have massive numbers in 18 months. It proves the merit of what you do, and it gives a massive benefit to your community, and it also is an active participation in value-based healthcare because you link the cost numbers to the medical outcomes that are in the medical records data. And all the payers have claims data. They don't have medical record data. So you have an enormous advantage of proving real-world value for what you do. So, I caught you before you fell asleep at lunch. Any questions? Look around the room for 5 familiar faces and start emailing each other. Thank you.